Waiting for everyone to log on. So my name is Yun Huang. I'm a neurology registrar at the Walton Centre in Liverpool. I'm also an academic clinical fellow in neurology and a member of the infection neuroscience lab here at the University of Liverpool in the UK. My research interest relates to infection and inflammation conditions relating to the brain. So I think I'm just going to go through some brief housekeeping rules for today for anyone who's joining us for the first time. So we'll have two speakers that will go on to talk about the topics of management encephalitis, as well as an opportunity to discuss. So this webinar is being recorded and will be shared with the Brain Infection and Global Knowledge Hub and the Global Health Network. If you want to have your language translated automatically, you can navigate to the closed caption function and select your language, and hopefully it will translate this webinar to your language. Because the number of participants that we have today, which we'll find out in a second, we have your cameras and microphones disabled, but please do use the chat function to introduce yourselves, to ask any questions and report any technical issues. We've got a dedicated time in the second half of the webinar where we hope to go through as many of the Q&A as possible. So it's absolutely fantastic event today. We have over 458 participants registered for this webinar from over 84 countries across the world, which is absolutely fantastic. And just to say that if you want to get a certificate for this event, we can wait for code at the end, and there will be a link to a feedback survey, and you'll be able to fill that out and you get the certificate within a month. So without further ado, it's my absolute pleasure to introduce our chair for the event today, who will go on to introduce the topic as well as our speakers. So Arun Venkatesan is a professor of neurology at Johns Hopkins University School of Medicine in the Department of Neurology and the Division of Neuroimmunology and Neuroinfectious Diseases. He studied biomedical engineering, followed by a PhD in microbiology and immunology from the University of California. He completed his residency in neurology and was appointed the faculty in the Department of Neurology at Johns Hopkins in 2007. He's also director of the Johns Hopkins Encephalitis Center, where he oversees clinical activities and research, has developed a multidisciplinary program devoted to delineating pathogenesis and optimizing diagnosis and the management of autoimmune and infection conditions that affects the central nervous system. His laboratory research focuses on defining mechanisms of the central nervous system injury and the setting of infection and neuroinflammation, with a goal towards developing protective and regenerative strategies in multiple sclerosis and encephalitis. His research has received funds from the National Institutes of Health, Howard Hughes Medical Institute, the National Multiple Sclerosis Society, and the Maryland Research Fund. So without further ado, I'd like to welcome Professor Arun Venkatesan.
Thank you, Yun, for that very nice introduction. It's a real pleasure to be here, and incredible. The global reach of this webinar series is really amazing, and welcome to all of you from around the world. We're going to be discussing, I think, a fascinating topic, certainly fascinating to me and to the speakers here, and I think it will be to you as well. The focus, of course, is on encephalitis, or as some of you may refer to it, encephalitis, which, of course, is inflammation of the parenchyma of the brain with resulting compromise of the nervous system. And it's caused by infections and by autoimmune conditions. It's a very challenging syndrome to diagnose and to manage, given the myriad of causes, both infectious and autoimmune, and the heterogeneity of presentation of the disorder. And as a result, there have been attempts to put together guidelines on how to diagnose and manage the condition. The last UK guidelines were published a little bit over a decade ago, and there have been a number of really incredible advances on both the autoimmune and infectious fronts since then. And so that's the goal today, is to provide you a bit of an update on what has happened in the past decade. So our first speaker today is Dr. Nick Davies. He is a consultant neurologist at multiple hospitals in London and at the UK National Centre for Human Retrovirology. He also chairs, among his many hats, he chairs the scientific advisory panel of Encephalitis International and truly is an international expert on encephalitis. Dr. Davies.
Thank you so much, Arun, and it's such a kind introduction. So I'm up to speak first, and I'll share my slides with you and hopefully get started. So I hope you can see my slides, and I will be speaking to you more from the infection side and more as an adult neurologist. So what's changed after the last decade? Well, it's actually more than a decade ago we started writing the initial set of guidelines. And in fact, Benedict Michael was a research fellow, I think, and he's now a professor. So that's a very major change to have happened in a decade. So I will plan to speak about diagnostic tests, particularly for identifying bugs, and talk about the spectrum of infectious causes we see here in the UK and what we've learned over the last 10 years, and then finish by talking about the cutting edge and how we think about those patients in whom the etiology for their encephalitis is not known. But I thought just to get us, so for those most sensitive for determining the cause, you'll be able to choose one of these. So is it first the polymerase chain reaction to detect microbial nucleic acid in cerebrospinal fluid? Is it 2 microbe-specific IgM assays applied to CSF? 3 microbe-specific IgG indices to show intrathecal or local production of IgG? 4 metagenomic techniques applied to CSF, or 5 none of the above. So do we have any poll results yet?
So Nick, I can see them here. So maybe you can elaborate on them. So the question was, which of the following diagnostic tests is the most sensitive for determining cause of acute infectious encephalitis? And 60% voted for the polymerase chain reaction to detect microbial nucleic acid in CSF. 19% voted for metagenomic techniques and 11% for microbe-specific IgM assays to the CSF.
Okay, right. Well, let's get back to the talk. So I think the answer is none of the above, because you need different tests in different specific situations. But more of that anon. But it got you thinking, I hope. So what of acute encephalitis? Well, of the syndrome worldwide, probably the incidence is between 5 to 8 per 100,000 per year. But obviously, in some parts of the world, there are epidemic causes which would lead to considerable differences in that instance. In terms of etiologies of infectious encephalitis, we think about sporadic and epidemic causes. Here in the UK, generally, we're more at risk of sporadic than epidemic problems. The commonest form of infectious encephalitis worldwide is that caused by HSV1, and its incidence is approximately 1 to 2 per 500,000 cases per year. The reason this matters is the outcome. And the outcome has been improved by many interventions, but is still considerable. About 10% of persons suffering herpes simplex virus encephalitis die, and 2/3 have a poor outcome. Even in those with an unknown cause of their encephalitis, there's still a 10% case fatality rate and 50% poor outcome. And poor outcome is defined in these studies as a Glasgow outcome scale of score, rather of 4 or less. And the reason that outcome is poor is usually because these patients suffer a significant acquired brain injury, and that has an impact not only to the individual, but to families and society as a whole. And retrospective studies using a large UK general practice database has shown very high increased risk ratios, not only for conditions such as epilepsy following acute encephalitis, but also psychiatric syndromes, including bipolar disorder and also alcohol abuse. So in the last 10 years, what have we learned about the causes of encephalitis here in the UK? Well, this summary slide shows the results of the DeFries study that collected patients 16 years of age and older with an acute encephalitis syndrome. So amongst adults, infectious causes are the most frequent, and particularly herpes simplex virus, but also enteroviruses. Yes, we see bacterial causes as well. Perhaps surprisingly, little listeria was captured in this prospective study. And in many contemporary studies of acute encephalitis, approximately 10% of cases are caused by Listeria monocytogenes. Autoimmune causes are common, and the most frequent form in adults is that associated with the NMDA receptor antibody, although these tend to be younger adults. Importantly, a large proportion, despite extensive investigations, have no etiology found. And of course, amongst these, we don't know whether these are infectious or autoimmune or autoinflammatory in etiology. Now, other things have changed as well, and this is a problem worldwide. So flaviviruses previously have not been a major issue here in the UK, but tick-borne encephalitis virus has now established itself here. Previously, it had been a problem in Central Europe in particular, but UK ticks now carry this vaccine, which is flavivirus, a member of the Japanese encephalitis virus family. It is vaccine preventable. It's here in our shores, and there have been tick-to-human cases documented. So this is probably results from climate change affecting the life cycle of ticks. Our winters are warmer, more of them survive over winter. Right, what about HIV? HIV remains a problem in the UK, highest incidence in urban areas. In the original study and, in the original guidelines and in our future guidelines, we make it very clear that HIV testing is mandatory in anyone presenting with an acute encephalitis syndrome. First off, HIV itself can cause an acute encephalitis. And secondly, the immunosuppression associated with HIV very significantly changes the spectrum of pathogens that we think of. So it needs to be considered early on. So when we think about causality in acute encephalitis, and this really relates to infectious causes, we need to think about the likelihood of an agent, an infective agent, microbe, with the likelihood of it being the causative agent of the syndrome that we see. And clearly, we can detect an organism within the brain itself, particularly following a brain biopsy, and we'll feel very strongly that if it's there in the substance of the brain with an appropriate inflammatory response, it's highly likely to be the etiological agent. But brain biopsy is an invasive process and something that seldom we go ahead and do. Finding the organism within CSF, which bathes the central nervous system, is helpful and specific, and so is finding a localized immune response within the CSF, whether that be an acute IgM, as would be diagnostic in many flaviviral infections, or whether it be a localized intrathecal response to a herpes virus. Whereas detecting an organism in a sterile compartment outside the brain, such as blood, or in a non-sterile part of the human anatomy, such as the gut, the bug detection may have relevance, but it's not specific. And this needs to be borne in mind when one looks at guidance in the forthcoming suggestions. So, what samples should one obtain? Well, cerebrospinal fluid is key and very important to obtain where safe, and that should be for standard microscopy, culture, etc. But on our guidelines, we also make a point of sampling non-sterile tissues such as throat swab, stool, urine, and these are important particularly for picking up enteroviruses, which may only have brief windows of PCR positivity in CSF, but are often present, particularly in stool, for extended periods following acute infection. So important to think about those. Urine, not only for the standard bacterial antigens, but again, following some flavivirus infections, particularly West Nile virus, there is extensive excretion in urine. And don't forget blood as well. And in the guidelines, what are recommended? Well, this really hasn't changed over the last decade. In immunocompetent adult patients, the first line PCR tests are to look for HSV1 and 2 and VZV DNA and enterovirus RNA. If bacterial causes are suspected, then undertake specific PCRs for strep pneumo, meningococcus, listeria, and if you're thinking about TB, use the TB GeneXpert Ultra PCR, which is a more sensitive TB test and something that was not available to us a decade ago. What sort of assays should be used in the lab? Well, multiplex assays are now offered commercially by a number of companies. These are good. Some assays, such as the BioFire assays that are very convenient and easily used, may have lower sensitivities than more traditional PCR assays, but have a role to play. Do you need quantitative PCRs? Well, in the context of HIV, almost certainly you do. And the reason is that if you find an excess quantity of HIV within CSF compared to the peripheral compartment, that can be of significant diagnostic information and imply a viral escape. And similarly, in certain situations where an infection is associated with reactivation, particularly in the immunosuppressed with bugs like CMV, then having a quantitated PCR assay can help you distinguish between local infection and systemic spillover. CSF antibody tests are still important. As I mentioned earlier, these are the cornerstone for diagnosing flavivirus infections. They're still very important for identifying CNS measles infections, such as in SSPE or inclusion body measles encephalitis, and even have a role to play in diagnosing herpes simplex virus or VZV-related CNS infections, particularly where the period, the CSF window for viral positivity by PCR is missed. So in terms of making the diagnosis retrospectively. So what's the future? And I think 19% of you thought that this was the gold standard for diagnosing infectious causes of encephalitis. So metagenomic sequencing. And this is exciting new technology. The idea is that from a sample, nucleic acid, whether it be DNA or RNA, is isolated. And from that, a metagenomic library is constructed, and then through computational analysis, that's is analysed looking for known pathogens. And this is being put into practice. Michael Wilson's group in San Francisco is perhaps a world leader in this area. And it shows interesting results. Now, it certainly does reveal new or unexpected pathogens, but what is the case is that it appears to be less sensitive than targeted PCR tests. And in fact, in that study that I quoted from 2019, some proven causes of encephalitis, of viral encephalitis, were missed with the metagenetic approach. We've learned that it's perhaps better when applied to brain tissue as opposed to cerebrospinal fluid. And if we're thinking about this for the future, we do need to think about ways in which CSF samples in particular are treated, and perhaps how we try and preserve fragile RNA for future analysis. So that is probably my time up. And I'd just like to thank everybody who's involved in updating the UK encephalitis guidelines. And here's a list of the names of all the people I think are involved, and I apologize if I've missed anybody out.
Well, thanks so much, Nick. That was really a fantastic update focused on advances in infections in encephalitis. I see a few questions in the chat. Keep them coming. I think what we're going to do is move on to Professor Ming Lim's talk, and then following his talk, we'll go ahead and field questions and allow both Dr. Davies and Dr. Lim to address them. So keep those coming in the chat. So it's next my pleasure to introduce Professor Ming Lim. He's a professor of pediatric neurology and the head of children's neuroscience at Evelina London Children's Hospital. He's led numerous multi-center and multinational studies on neuroinflammation in children and in adults. And he'll be speaking to us today on updates in autoimmune causes of encephalitis. Those of you who know him know that he's typically very cool and calm and collected. And so we've decided to challenge his poise by pulling a fire alarm in his building. And he's going to be joining us from his phone, and we'll see how he does with that. Professor Lim.
Thank you very much. I wish I could show you the sunnier bits of London, but this is from a car park next to the hospital. So I'm going to tell you a little bit about, the last decade in terms of the development of the immune aspects of, encephalitis. And in the first slide, I was going to put up the poll, and the poll is going to be, as it reads there, what is the commonest identifiable cause of encephalitis? And as some of you will recall and know, the guidelines were written sometime in 2012, and it's about 3 to 4 years before a very recognizable antibody-mediated condition was reported by Professor Dalmau, and that features as one of the choices. So this is not an entirely loaded question at all. But all the other viruses that we see in both children and adults, the herpes simplex virus, varicella zoster, COVID, of course, and the two, antibodies. So I'm going to let you think as to what that might be. And I'm delighted that all of you have chosen herpes simplex encephalitis or virus as the commonest cause, because we will soon reveal to you that the answers are indeed in the immune-mediated encephalitis. So 2 lines of evidence support that. In the encephalitis program in California, from historical samples of patients kept when they went to be reinterrogated again for antibodies, in unidentified, causes, we know that about 4 times more patients with NMDR were identified compared to HSV. I was going to allow those who said MOG because that's my favorite antibody. Although the reason for that is really that the data is just evolving, as such. And we'll come back to that a little bit later. But in the most comprehensive study to date, it is probably as similar or probably higher frequency than NMDR encephalitis when you interrogate, a sample of patients with autoimmune encephalitis. Okay, so I think a key change in the way we think about encephalitis, like in all sort of neuroinflammatory condition, is essentially the 2 components of the immune system, the innate and the adaptive. And of course, all of you will be very familiar of the innate being directed at infection. It is non-specific until you've had a previous infection, whereby a whole host of memory mechanisms provide you with a means to augment the host response subsequently, and this would be the adaptive immune system. And many aspects of the immune system can be interrogated, and more commonly, each of them may have different conditions or syndromes that you're more familiar with. And if we click on the next slide, it's traditional that if you think of the adaptive system being upregulated, we tend to call it autoimmune, and hence autoimmune encephalitis. And an evolving spectrum of these conditions are the autoinflammatory encephalitis. And the next slide will highlight the spectrum of some of these conditions that came to fore perhaps during the COVID period as well, whereby infection can trigger a group of inflammatory conditions that affect the brain. Some of you, particularly those who work with children, will be more familiar with ANEC, which is acute necrotizing encephalopathy of childhood, but I've taken the childhood out here because you do see it in adults as well. And this is not meant to be an exhaustive list, but a list of the syndromes that we generally recognize. And ultimately, a group of us are working on trying to characterize them now, initially just being able to define them by an established criteria that is not neuropathologically based, but syndromically based. And essentially, these are a group of conditions that are infection triggered, that do have predominantly an inflammatory or a para-infectious pathomechanistic sort of mechanism, but also an excitotoxic mechanism. So I'm going to park that there for now whilst we move on to the next slide. And that essentially is, and I think you might have to click that again, to highlight the new kid on the block, so to speak. And this is MOG, antibodies. And so for all of you that know MOG antibodies from a neuroinflammatory perspective, we know that it's a condition akin to, MS, whereby you have a recurrent, demyelinating syndrome, although not necessarily in all patients. And there has been a very recent consensus agreement on, or proposal, so to speak, of what the criteria should be. But the reason why it's relevant to encephalitis is really that in a big proportion of patients that present with MOG, there is a cortical phenotype. And if you click on, we will start rolling the cortical involvement. And this really started some years ago, where in a group of patients, it was recognized that it looked very much like, encephalitis or meningoencephalitis. And in some of this imaging, there are characteristic features that actually don't look that different, to encephalitis. And the spectrum of this is growing. We move on to the next slide. And in a recent publication from the Spanish group, Davies and Professor Dalmau, in addition to looking at the demyelination phenotype, they had a chance to interrogate the autoimmune phenotype, samples of patients who were essentially not identifiable in terms of antibodies. So those would have been antibody negative at one stage. And in a significant proportion of them, if you click the next slide, and that 7% of them, they had MOG, antibodies. And if you were to analyze that data in terms of patients that were entirely antibody positive, which is the next slide, we found that, or they report that, MOG was, almost at the same frequency or slightly more frequent than NMDR encephalitis. So hence the result of the poll accepting that MOG may be more common or as common. And I think that's just the beginning of the iceberg, because the last part of the jigsaw is going to come when the likes of Professor Michael are telling us that from his encephalitis cohort, X number of patients will have MOG antibodies. So we're awaiting that. So if we move on to the next slide. So like with all things, there is an expanding phenotype. We see them in patients with fulminant cerebral edema. I already mentioned the cortical phenotype, which is what you will see in the next, if you press again. And then there are also seen in patients with very refractory seizures, and sometimes very similar to another phenotype that the neurologists see, which is virus or NORS. And these are new onset status epilepticus. If you click on the slide, it will, and some of these patients with virus and NORS will share a spectrum of changes that will cross the phenotype or the boundaries of the phenotype. Some will have fulminant edema, and some will have the meningoencephalitis or contrast, enhancement, or leptomeningeal sort of enhancement. And more recently, as we look into the cohort of patients that we have with MOG, we think that up to 15%, or you see that 14% have this cortical phenotype. So it's a big component. Okay, so the next poll. Amongst our treatment decisions, if you suspect that someone had immune-mediated encephalitis, what are the factors which would predict a poorer recovery or better outcome either way? So is it delaying first-line immunotherapy? And conventionally, by first-line immunotherapy, we generally mean steroids, IVIG, or plasma exchange. Or do you think we have, more specific knowledge or data that certain first-line therapy is more effective than others? And it would be tempting to think that plasma exchange, for example, would be sort of beneficial. Or perhaps might you think that rituximab, which is the second-line, treatment, may be, better. And then the third, of course, is, not treating the trigger, i.e. the viruses or maybe the tumors. So we will await the result of the poll. And I'm delighted this time that I did not trick you all. It is essentially the delay of not starting first-line therapy that is the biggest determinant of outcome. If we move to the next slide. And just bearing in mind that this is essentially a data on NMDR encephalitis, and of course, we extrapolate a lot of our knowledge to that, and in the next sort of decade. So when we come to the next, iteration of the guidance, we may have data on MOG and a few others, but for now, we are reliant on that. And in this meta-analysis, and this is individual patient data, whereby it's extracted from all, case reports, and this was 1,500 cases, we can see, or you can see there that all of the first-line therapies used either in conjunction or one or the other incurs, a benefit. And then if we move on quickly to the next, and this just demonstrates that over the years, there has been increased usage of rituximab, and this correlated with a reduction in relapse risk, but also if used within 60 days, incurred in benefit in outcome. So this remains the most robust data, that we have, that early treatment makes difference. If you move on to the next slide, and it's really, the basis of many reviews now, and each of them concluding that early and adequate rather than aggressive immunotherapy really improves outcome in and neuroinflammation. We won't have time to discuss the sort of nuances of some patients recovering, as Arun mentioned earlier, the heterogeneity of sort of responses, but that's the general theme as such. And if we move on to the next slide, and this is just a couple of slides to give you a sneak preview of what might appear in the consensus guidance that will come out in, we hope, soon. A diagnostic algorithm for diagnosis of autoimmune encephalitis. And then the next one is perhaps a treatment algorithm. So if you click again, a stepwise sort of increment, including some suggested, timelines. And the reason for showing this very briefly is that this gives you an idea of the framework we're thinking about, but the details may change as we evolve, refine, and finally, approve the consent. So if we move to the next slide, I just wanted to end on two points, and the one point that we commonly, get asked is whether the diagnostic criteria is specific or sensitive enough. And it's very clear from this very nice work from a multi-center, predominantly North American data, suggesting that the only time we get it wrong is if we don't use the criteria properly, rather than over-diagnosing autoimmune encephalitis. And in the next slide, or not the slide, the next component of this is that there's always a concern, particularly in our immunotherapeutic strategy, that we would start steroids before, confirming that there's no infective etiology. And although not set out to be a meta-analysis of a safety signal in given steroids, in this meta-analysis, there wasn't a signal identified, i.e. patients given steroids did not suffer more morbidity if there was an infective etiology as such. So I hope they've given you a whistle-stop tour of all the things that I've been involved with in the last 10 years, which has been exciting, which is the sort of mushrooming of the autoimmune, and I'm sure in the next years or so, the autoinflammatory encephalitis, and we hope this would feature both in the adult and pediatric components of the new guidance. Thank you.
Thank you so much, Professor Lim. That was a fantastic update on autoimmune etiologies in encephalitis and how to both diagnose and treat them. We do have some questions in the chat for both you and Professor Davies. So first, for Nick, a question came up. What is the influence of COVID-19 on encephalitis cases, and more specifically, potentially on reactivation of HSV?
SARS-CoV-2 can very exceedingly rarely cause an acute encephalitis, but mostly what we've seen with it has been encephalopathy. In terms of causing HSV reactivation and HSV encephalitis, or being a trigger for that, that's not something that I'm particularly aware of. Maybe there's data there that I don't know of, but I see no reason why there mightn't be an association there.
Yeah, thanks. There's a kind of a correlate question to that perhaps Ming can take on. So the previous question asked whether one infection might trigger another. This question relates to how infection may trigger autoimmunity. And so the question is there a relationship between infections and MOGAD? And if there is, do the infections alter the phenotype that is seen?
Sure. I think there's two levels of sort of questions there, and I think the first is one always assumes that the autoimmune trigger is a direct one and a fast one, meaning that you get the infection a month ago and this is the event, and of course priming of the immune system such as in a chronic inflammation like MS, there might be a lag, so that could be 2 years or 3 years. So from that point of view, it's difficult to be certain that there is a definite sort of signal. Certainly from MOGAD, when we've recently had the largest sort of COVID sort of infection, if you look at the COVID rate of COVID infections itself and triggering MOGAD, i.e. the percentages, then I would be hard to convince myself that there is definitely a more virus-mediated pathogenicity from sort of COVID. So in answer to the question, I don't think there is a specific viral trigger, and nor is there a specific difference in the MOGAD presentation, other than in the COVID period, whereby there have been a few reports of slightly more severe phenotypes, but I think that is unclear, and that has not been sustained in subsequent years.
Thank you, Ming. Let's ping back to Nick. There's a question about CMV and EBV, and when they're found in the CSF, are these, quote, real pathogens, unquote?
So a very good question. And I think it, of course, like everything, it depends on the clinical situation. So first of all, are you dealing with an immunocompetent or an immunosuppressed patient? In somebody who's immunocompetent, then if it coincides with primary infection with one of those organisms, which can be determined serologically or from your history, then it may be of relevance. In the immunosuppressed situation, in the immunosuppressed situation, they're often more likely to be of relevance. And again, when talking about the use of quantitative PCRs, this is where those can be very helpful in determining whether what you're detecting in the cerebrospinal fluid is a local problem, i.e. with high copy numbers, or whether actually what you're detecting are a few copy numbers that are overspill from systemic reactivation.
Thank you, Nick. There are a couple of questions that are related to encephalitis in low-resource countries, and so I'm going to ask both of you to address these. One of them refers to the epidemiology of infectious versus autoimmune causes of encephalitis in low-resource countries. Particularly, this question was related to Africa, the continent. And then the other question has to do with key clinical differences in, I think what the question is getting at is in types of encephalitis that might allow you to diagnose the specific etiology when CSF analysis and imaging may not be readily available. Nick and Ming.
I'm going to start by saying that this is perhaps the two questions that we would be the most ill-equipped to answer, but we'll clearly make a stab at that. So certainly for me, in an autoimmune versus infectious, sort of paradigm, the notion of, as we always say, fever, is the key feature. But in addition to fever, the syndrome of having an infection itself, i.e. a respiratory tract infection or something, and those coexisting would certainly make you more concerned that there is an infectious sort of etiology, and the key having the post-infectious, having the infection, the recovery, and then a new neurological syndrome would then always point towards it being an autoimmune or sort of an immune-mediated etiology as such. But there's always the in-between, that there's a para-infectious component whereby the patients are just very close to the infection, and then they have a secondary neurological decline where we're less sure. And I think a lot of you will be familiar with the literature that if you look exhaustively, across in terms of every single feature, other than features that are very distinct of the immune syndrome itself, like let's say dysautonomia in autoimmune encephalitis, or a very characteristic movement disorder, the specificity and sensitivity of each of the symptoms are quite difficult to make you feel confident it's one or the other. And I think the second bit to the question here is really that maybe we shouldn't be worrying too much about distinguishing the two, because treatment of both may be something we would consider. But how we would consider that would really be dependent on your sort of pre-test probability of the likelihood of that within your population, I would have thought. And I'm not even going to touch the other question. I'm going to let Nick do that one.
Yeah, so again, I'm no expert in practicing medicine in resource poor situations, but to stress, patients with acute infectious encephalitis usually demonstrate signs of infection, i.e. fever. And infection is something that is diagnosed at the bedside. So yes, there are clues. Secondly, I think history-wise, and for the most part in adults at any rate, the time course of presentation tends to be very different between autoimmune forms of encephalitis and acute infectious forms of encephalitis. Without molecular tests, what can be done? Well, certainly CSF analysis and at least being able to get a differential on CSF can help you. Could I distinguish clinically without high-tech imaging between an abscess in a temporal lobe presenting with fever and seizures and herpes simplex encephalitis? I don't think I could without neuroimaging. So some of these things are tough, and sometimes, I think one has to treat empirically. And of course, again, as Ming was saying, you need to know what's common in epidemiologically in the area that you practice in. So for many parts of sub-Saharan Africa, obviously high incidence of untreated HIV and immunosuppression, cryptococcus is going to be high up there as a common cause of CNS infections. And malaria as well, which is something that in the UK, we only see occasionally as an imported infection, but of course can cause high fevers and encephalopathy.
Well, thank you both. We're running a little bit short on time because we need to transition to the last portion of the webinar today. But as you can see, there are lots of questions, many that we haven't gotten a chance to address. And I hope that perhaps with the publication of the new UK guidelines, many of these questions will be addressed. Of course, they will spur additional questions as well. So thank you so much, Professors Lim and Davies. That was really fantastic. Enjoyed the talks and the discussion that followed. Let me turn now to Greta.
Thank you very much. What a really brilliant session, and such interesting questions as well, coming from people all over the world. So this is just a slide about how to get a certificate for the session. So there's a QR code in the middle. I'm sure the team from the Global Health Network can also put the link in the chat. And so if you want a certificate for today, there's just a very short feedback survey that's really helpful for us, and then there's a certificate available. So now we want to just do a very quick poll just to ask you about whether this session will have a change in your practice, or whether you'll use what you've learned today in your setting. So if we could launch the impact poll, please, from the Global Health Network. It's just 2 quick questions. Will take less than 30 seconds. And then we've got a couple very exciting things. We're going to announce the winner of our Changemaker Challenge, which is brilliantly exciting. And then we'll go on to share some opportunities for potentially meeting in person at the Encephalitis Conference, and some scholarships and things like that. So please do stay right to the end. Okay, brilliant. Thank you very much. That's great to hear. And we'll move on now to the Changemaker Challenge. So this is my enormous pleasure and privilege to share. So we join each month, people all over the world, and they're brilliant sessions, but we wanted to know, is it changing anything in the real world? Is it changing anything in practice? So we started our Change Maker Challenge. We asked for video submissions, and we got some prizes. The most exciting one for the winner being free attendance in person at the NeurID teaching sessions in Liverpool, with $800 towards accommodation and travel. And then runner-ups get a virtual place at the Encephalitis conference. And this session, it was judged by a member of the WHO Brain Health Unit independently. So every submission was seen by someone at the WHO. And now to announce our runner-ups and our winner. So our first runner-up is Dr. Sarah Braun, who's working at Lusaka Teaching Hospital in Zambia. And they told us that they'd joined our sessions and they'd set up the first stroke unit in Zambia. They do capacity building to provide local, sustainable and specialist care for stroke patients. And they win a virtual place at the Encephalitis conference. Our next runner-up was Dr. Cherise Okafor. She works in Regions Healthcare in Imo State, Nigeria. They joined our session on telemedicine, and they started including sort of virtual technologies in their charity epilepsy clinic. They trained 20 EEG techs, and they have 1,500 epilepsy patients visiting each year to their charity clinic. And the final winner, with an absolutely amazing project, was Dr. Mundi Njojam. So she joined our our patient and public involvement session last year, and she was inspired by the work of Prof Bindu Menon in India, and started her own work in Cameroon to raise awareness and early detection and reduce stigma for epilepsy. She trained 25 young people, and over 12 months, they reached 10,000 students in 200 schools. And they saw lots of impact, but crucially, they saw an increase in presentations in their local healthcare facilities. So congratulations, and I look forward to seeing you in December at the Encephalitis conference. Now I'll hand over to Dr. Huang to announce the opportunities.
Thanks very much, Greta. So just for the last couple of minutes, just to discuss some of the research and education opportunities. So if we go to the next slide. The first one is invitation to collaborate for prospective and international observational study assessing the global variant in patient characteristics, management and outcome of spontaneous intracranial hemorrhage. This is a 30-day collection data period, and it's available for any hospital managing patients with intracranial hemorrhage. So if you're interested in finding out more about the study, please scan the QR code. Alternatively, there's an email address as well if you have any further questions or interested in enrollment in the study. So the next one we have is a PhD opportunity here at the University of Liverpool as part of the Liverpool Clinical PhD Programme for Health Priorities in the Global South. It's available for any UK registered healthcare professionals, and the successful applicant would be spending at least 2 years in a low and middle income country. So the next one is our locally developed resource here at Liverpool, which is a neuro resource centre, a collaborative network where we've developed a range of different tools and resources to help healthcare and researchers in the field of clinical neurology. And all you need to do is fill out a simple registration form, and you'll be able to access these research tools, and hopefully be able to help you with unifying some of the methods and results for your research. As well, we've got the Brain Infection Global website, which has an excellent range of free e-learning modules on a range of neurology infectious diseases, and the range anything from lots of different languages used, and is aimed at medics of all different grades. And if you are successful in completing the quiz at the end, you'd also get a certificate for the e-learning module. Next is a really fantastic opportunity. So if you enjoy this webinar and you want to find out more about encephalitis, annually there is an encephalitis conference held by Encephalitis International, which is virtually as well as in person in early December, held in London. I've been to these conferences myself in the last couple of years, and been really, really amazing opportunity to learn about the upcoming research in the field of encephalitis, as well as networking. interesting. And what's also exciting is that the Encephalitis International provides free in-person and virtual spaces to anyone interested who is from a low-income and middle-income countries, as well as bursaries to attend in person every year. So do please check out the website. And I think the registration is either open now or be open very soon. So next, we've got the Global Neuro Research Coalition, which again is a fantastic collective network of neurologists, neuroscientists, and allied specialist profession. And it's a platform where you can exchange ideas, you can share the latest research. And it's an emphasis on harmonizing research strategies and to help to tackle problems of global neurology. And the final opportunity to mention is coming from the World Federation of Neurology as a range of excellent, again, e-learning modules for many neurological conditions if you wanted to learn more about neurology in general. Right, so I think that is coming to the end now of our very last global brain health and clinical exchange. So I'd like to take this opportunity to thank everyone who has attended a clinical exchange over the past 3 years, and also to thank and acknowledge our funding, who are the WHO Brain Health Unit and the University of Liverpool in the UK for making all of this possible. Thanks very much, everyone.